I'd like to welcome you to this edition of the PRS Journal Club podcast with your hosts, Dr. Sammy, Sinno, Amanda Silva, and Sawh-Martinez. Enjoy.
Hello, everyone, and welcome to the February 2016 PRS podcast. I'm Sammy Sinno, and I'm joined by my co-resident ambassadors, Sawh-Martinez and Amanda Silva. We are very honored today to be joined by our special guest moderator, Dr. Paul Cederna. Dr. Cederna is, as everyone knows, a real pioneer in clinical education research. He's the chair at University of Michigan, plastic surgery, which is one of the best and historic programs in our country, and also a real leader nationally in serving in the board of directors for PSF, ASPS, and the American Board. Dr. Cederna also happens to be section editor of the experimental section of PRS, so we're very happy to have him, and welcome, Dr. Cederna.
Yeah, thank you very much for that kind introduction. I really appreciate it. I just wish my family were here to hear the introduction.
Well, we'll email them. We'll email them a copy of the podcast for
Perfect.
Sure. So, without further ado, let's get into the first of three great articles this month in PRS. This one is entitled "The Importance of the Upper Lateral Cartilage in Rhinoplasty." It's by the Dallas group, Dr. Rohrich et al. And this is a special topic that I think is really great for residents trying to learn rhinoplasty. I'm always trying to learn anything I can about a procedure to me that seems so technical and something that you really need to spend years and years understanding, spending time with to fully comprehend. And I think this article does a great job of focusing on one anatomic component of rhinoplasty and really explaining, I think, everything you need to know, whether you're a novice like me or even a master rhinoplasty surgeon. And basically the key concepts after reviewing the anatomy of the upper lateral cartilage is to talk about the importance of the dorsal aesthetic lines and why it's important to restore the upper laterals when doing any dorsal reduction or dorsal component hump reduction. And he gives the three approaches that they commonly use, which include the use of what's called the upper lateral cartilage tendon spanning sutures, as well as spreader grafts or auto spreader grafts. I also talk a lot about the importance functionally of the upper lateral cartilages in terms of the internal valve and the influence of the upper lateral cartilages in terms of achieving nasal tip rotation or shortening. So overall, I think this is an outstanding article. You can check the Resident Gateway for some terrific paired articles that go along with this reading. And I think I wanted to ask Dr. Cederna his opinions on education in rhinoplasty and what your views are in terms of what are the best ways to teach rhinoplasty, something that has always been difficult to teach residents, but particularly with an increased focus by the ACGME on aesthetic surgery. How do you think articles like this can really highlight and complement the resident exposure and experience in learning such a difficult operation?
Yeah, thanks for the question, and also congratulations on a nice summary of the paper. Rhinoplasty is a particularly difficult subject because the anatomy is complex and a bit abstract when you look at it 2D on a piece of paper, when it's actually a very dynamic 3D structure when you're trying to understand the relationships of all the various bony elements and cartilaginous elements and the responses to soft tissue to those elements. And so I think to really understand rhinoplasty, it requires articles like this to really get the good basic concepts, but then it really requires moving into the operating room, moving into the anatomic labs and into the operating room. Doing these operations, seeing the relationships and seeing the various impact of maneuvers on nose position, nose shape, nose dimensions. So I think those are incredibly important elements, and that's why when we do rhinoplasties, we do a lot of open rhinoplasty so people can really see the anatomy better than you can when you're doing a closed approach. There are a couple of really important topics that maybe you could just talk a little bit more about. They talked a little bit about spreader grafts and spreader flaps, but I was wondering if you could sort of delve into that just a little bit and talk about what the difference between those is and what the impact on internal nasal valve area and things with those two approaches.
Right. Well, that's a great topic of importance, not only for us to understand for rhinoplasty, but for examination purposes. And really, if you want to increase the internal valve angle, which is essentially formed by the upper laterals and septum, to improve airflow dynamics, you have a couple of options. And one, you can use traditional spreader grafts, which commonly are derived from the septum, which is favored due to its, compared to the ear, more straight configuration that can be used to increase the angle of the valve by opening the angle over, let's say, 10 degrees, which is sort of the minimum valve angle needed for proper airflow. Also, auto spreader grafts can be used if there's a redundancy of the cartilage to flip in and also serve as a mechanism to prop open the valve. What I think is interesting in sort of reading Dr. Rohrach's articles over the years, and we do owe so much to Dallas for teaching all of us about rhinoplasty. And it's interesting, it seems as earlier in his career, he almost universally used spreader grafts in his rhinoplasties. And now I think even in this article, he goes out of his way to point out that he doesn't necessarily always use spreader grafts. In some situations, it's actually preferred, if not needing to use an actual graft, to use what he describes as the upper lateral cartilage tension spanning suture. So to me, it's an important distinction to know that you can use an auto spreader graft, you can use a classic spreader graft, or you may not need it. And to see how somebody that's really a master rhinoplasty surgeon has evolved their own technique over the years is something I think that's also important to pick up as a subtlety of this article.
Yeah, I think those are really good points. It is interesting to see the evolution of technique, but I think that's what happens in any procedure that we do. If you're not critically assessing your outcomes, you're not getting better. So every single time you're doing a case, you're critically looking at your outcomes, and after you see a few and you see some trends, you may decide to adjust things. So all of us are constantly making minor adjustments in how we do a case, even if we've done 500 of them. We can always make it better, and we're always adjusting. And it's also interesting because you do hear a lot about spreader grafts, but there's no question about it. When you use a spreader graft, you make somebody's nose wider every single time. You may need to. If you don't tell someone you're making their nose wider and you put some spreader grafts in there, it could be a potential problem postoperatively from an aesthetic standpoint.
Right. Yeah, absolutely. One of the gifts of this paper is it really sort of hones in and focuses on just one, specific aspect of the rhinoplasty with upper lateral cartilages. And I think one of the things that I got out of this paper that's really valuable are two big things: is the preoperative assessment of what the patient's needs are, whether they're having functional issues with breathing and whether the chiroplasty will be helpful or not for the spreader graft. Then also looking at everything in context, how wide, how tall is their mid-vault already. In addition to that, with the sort of specific anatomical variants that can come up with the upper lateral cartilage, to know whether or not the patient may even be a candidate to use the spreader flaps instead of the graft itself, in case you don't have a septum, if it's a secondary procedure, etc. And I think that the detail in the analysis really is what makes the difference in what we can and cannot do, or can and should not do with these upper lateral cartilages. And just like Dr. Cederna is saying, I think the impact on the outcome is something that understanding the pre-op eval analysis will make that critical difference, right, for what we do and don't do with it.
Absolutely. I think that's and probably one of the harder things to learn is be able to go into an operating room with your attending with the pictures hanging up and be able to on the spot sort of analyze the nose. And obviously, I think a lot of the examination for rhinoplasty doesn't just take place by looking at pictures, but obviously placing your hands on the nose, feeling the quality of the cartilage, nasal bones, looking inside the nose. But I think a lot of it, Raj, as you said, has to do with your ability to analyze the nose in sections from different views. And I think, we all owe a lot to Dallas and everyone that's taught us so much about rhinoplasty. And for me as a resident that's still trying to learn as much as I can about this procedure, I think this is another great article to have in the armamentarium. So with that, I think we can move on to the next paper.
Yeah, I think so.
Well done, guys. That is good.